Obviously, okay, so I'm being recorded. All right, I'll be very nice about what I'm saying. Uh, it's asking me to hit continue. All right, I'll hit continue. Um, but anyway, I got in a lot of trouble for this picture because my grandmother yelled at me for wearing a T-shirt when I met the President of the United States. Next slide. Now, this is a talk that I've given multiple times over the past couple of years. I've had to cut this down twice in the last month. I gave grand rounds at Princeton Medical Center, and they only gave me 20 minutes to talk. So I went from 50 slides to 25 slides, and then I changed it around a little bit because I'm talking more about hepatitis B. But you can see there's a lot of different things to talk about. Next slide. So let's concentrate a little bit on HCC, hepatocellular carcinoma, or hepatoma. It's the 5th most common cancer in men, 7th in women worldwide. So worldwide, this is a major problem. Not so much in the US, but worldwide, it's a much bigger problem. The second bullet is just amazing. It's the 3rd leading cause of death from cancer worldwide. And when I gave my lecture last time, it was an hour lecture with my colleague, and I basically told the audience that in the hour that we're giving our lecture, 70 people around the world will die of HCC. So it's probably a little bit greater than that now, but still, it's probably close to 75 or 80 people are going to die in the hour that we're going to be discussing things. As opposed to other cancers where the incidence and death rates are going down, we're seeing an increase. And worldwide, it's primarily due to hepatitis B, somewhat hepatitis C, but both alcoholic liver disease and NASH are making a big comeback. The global HCC rate, death rates there. The majority of these cases come in people who live or are from sub-Saharan Africa, Southeast Asia, and Eastern Mediterranean countries. Now, the last bullet slide is the most encouraging thing I can tell you about today's talk. When I first started, and I started a little bit before Dr. Finkel, the 6-month survival for HCC was about 5%. Now, 5-year survival is about 80%. But the trick is to find these cancers at an early stage. So it's no longer a death sentence if you catch it early. And we really have to catch it early. And I don't know if I should be telling Dr. Finkel this, but I'm only working for another 9 years and 6 months. And during that time, my goal is to try to prevent as many people of dying from HCC as possible. Next slide. Okay, let's talk about HCC globally. And before I say anything, I forgot to tell you that my slides are primarily from Dr. Robert Gish, who's on the Hepatitis B Foundation, the medical director, and also from the Chronic Liver Disease Foundation. So both of them were kind enough to share their slides with me and other people, and I basically took it from them. So the first bullet is, in the majority of countries, HCC accounts for up to 90% of all primary liver cancers. The second bullet, we talked about hepatitis B. Now, the annual incidence rate of HCC in chronic hepatitis B patients ranges from 2 to 5% a year. The lifetime risk is about 15 to 25%. So if you think about it, you're in a room with 4 people with hepatitis B. One of them during their lifetime will develop HCC. And the interesting thing is, while we're seeing decreases in the incidence of hepatitis B infection after universal vaccination program of infants, we're still going to see, it's projected, an increase for at least the next 2 decades. So it's still going to be a major problem for the next 10, 20 years. Next slide. There are clear global disparities in the frequency, with the largest burden of disease is concentrated in countries with developing economies, 85% of those cases. Africa, Asia. And what's interesting is that HCC cancer related to hepatitis B occurs at a younger age in Africa, at a median age of 40 years versus Asia, where it's about 55 years. Now, along those lines, we've had at Penn, since I got there 3.5 years ago, about 5 or 6 individuals, all young, ranging from a 15-year-old to a 50-year-old, all have presented with terminal HCC because they either didn't know they had hepatitis B or they weren't being screened adequately, despite the fact that they knew they had it. And it's just so sad. One of our patients was in high school, a soccer star. He was supposed to go become a college soccer player. Before he died, the Philadelphia Union was nice enough to sign him to a one-day contract so he could be a professional soccer player before he passed away. And again, a totally unnecessary death from hepatitis B-related HCC. And his, if you Google it, it was in his obituary was in the Philadelphia Inquirer. Next slide. Okay, what are some of the risk factors? Now, related to hepatitis B, there are direct and indirect mechanisms. There's something about hepatitis B, and when it gets integrated into the host's genome or DNA, that it does produce a potentially carcinogenic situation. Is it proteins, genetic instability? We're not sure. But it's clear that as opposed to other types of liver disease where you usually need cirrhosis, you can get cancer related to hepatitis B in the absence of cirrhosis. The only other disease that comes close to that is fatty liver, but not to the same degree as hepatitis B. And the second mechanism are indirect mechanisms. The hepatitis B causes chronic liver disease that causes inflammation, fibrosis, development of cirrhosis. And definitely cirrhotic patients are much more likely to get hepatomas than non-cirrhotic. The second bullet talks about other factors: male gender, older age, family history of HCC. This family history of HCC has to be taken seriously. And it's an indication to even think about treating someone with Hep B. The higher the DNA level, the genotype, the ALT elevation, if you've been exposed to other things like aflatoxin B, alcohol, tobacco, all those things are risk factors and can be used to help prevent liver cancer. Next slide. You can see that there's a variation across the world with liver cancer. But if you look to the right-hand slide, it's talking about hepatitis B infection in Africa and Asia, where it's about 50% of the HCC worldwide. But everywhere along this map, there's evidence of HCC. Next slide. Okay. And this was said before, so I won't spend too much time on this, but HCC is the most common cause of liver cancer in the US. Next. This slide looks at HCC development, not necessarily related to hepatitis B, but typically you need cirrhosis, and then a nodule develops, and over time it turns into a cancer. So the current therapy is to do an ultrasound every 6 months to look for liver cancer, and I'll talk a little bit about that in a few minutes. Next slide. This slide is changing in the US. The viral hepatitis causes most forms of HCC, is the most common cause of HCC, primarily hepatitis C, but we're going to see that drop, but it's followed by hepatitis B, alcohol, cryptogenic, fatty liver. But for the next decade, at least during my career, we're going to be seeing a lot of HCC. Next slide. So how are we going to present? Let's go slow. How are we going to prevent hepatomas in the US? Number one, we have to find and cure all the Hep C patients. Next. Find and suppress the hepatitis B patients. We cannot currently cure Hep B. I'm hoping that we will in the near future, but I think it's going to be a lot more difficult, despite what Dr. Block says. Next slide. No smoking, minimal alcohol. Next. Avoid obesity, diabetes, fatty liver. These are just awful cofactors. Next. Coffee and tea are helpful. Doesn't have to be caffeinated. Decaffeinated is good. There's something about antioxidants in coffee and tea that protect against liver cancer. Next. Statins may play a role. My colleague, Dr. Kaplan, is doing a VA study, a prospective study, as opposed to some of the retrospective studies that have come out, where half of the VA patients with cirrhosis will be given statins, half will not, and we will follow them over the next 5 years to see if there's a clear difference in cancers. Next. And for some of those of you in the audience who indulge, this may be a good thing. I'm not sure if I believe it, but there was an abstract that showed that marijuana smokers had less HCC. Next slide. So these things have to stop. You cannot go out and eat a 5,000 calorie meal, which I used to do, and that's how I developed fatty liver. Next slide. Also got to put away the vodka. You can have it every once in a while, but really, I have 2 rules about alcohol. The safest amount of alcohol for your liver is 0. If you can't adhere to that rule, I have the 1, 2, 3, 4 rule. 1 to 2 drinks, 3 to 4 times a year. A lot of patients substitute month or week for that, but it should be really every once in a while alcohol. Next slide. This was a little study in one of our journals. One of my partners is the editor, but they looked at coffee, and it really looked retrospectively that it reduced the risk of liver cancer. And there was an inverse relation with elevated liver enzymes, cirrhosis, and HCC. And it looked like each additional cup of coffee a day led to a benefit. So as somebody who has fatty liver, who's at risk for cirrhosis, a risk for liver cancer without cirrhosis, I have 2 cups of coffee a day, and then my 3rd cup is either tea or coffee decaf. Next slide. Okay, this is an old slide, but it really talks about all the different societies and what their recommendations are. And one of the reasons why I keep it up is if you look at the Japanese Society of Hepatology, they actually have a high-risk category where they do an ultrasound every 3 to 4 months. They do blood testing every 3 to 4 months. They do a CT or an MRI every 6 to 12 months. So in some situations, there's recommendations to really aggressively look. In this country, the standard recommendation is an ultrasound and an alpha-fetoprotein every 6 months. I think the alpha-fetoprotein is optional, but it's clear to me that these guidelines are not great. And let me explain why. I think ultrasound is not as good as CAT scan and MRI, but from a cost standpoint, it probably would be too expensive to screen everybody who needs to be screened with an MRI or CAT scan every 6 months. As the cost comes down, and I think it will in the future, there's no doubt that we would be doing MRIs every 6 months. CAT scans, in my opinion, are a little bit dangerous because of the radiation exposure. The bottom line is everybody agrees cancer should be looked for. It should be screened. Next slide. This is from the AASLD guidelines. Nora Teralt put this slide together. All patients with cirrhosis should be screened with ultrasound plus minus alpha-fetoprotein every 6 months. If you don't have cirrhosis and you have FB, these are the groups that should be screened. Asian or Black men over 40 years old, Asian women over 50, anyone with a first-degree relative with a history of HCC, patients with a Delta co-infection. Some people argue if the DNA level is high, you should be screened. You should do a CAT scan or an MRI if someone has obesity. The ultrasound is not as good. Let me just say this. I think that ultrasound is crucial, but so is alpha-fetoprotein. And in my own practice, If I can get away with a CAT scan or an MRI, I do that at least once a year, hopefully twice a year. Depends on the insurance company. And I'm sure Dr. Finkel can agree with this. I've had many patients, probably 20 in my career, maybe more, who had ultrasounds that didn't show cancers, but had an alpha fetoprotein that was up. And then we do a CAT scan or MRI and we see 2 to 4 cancers. I have a patient get an ultrasound as part of their routine screening, no cancer. They go to the ER next month with a kidney stone, CAT scan shows a 5-centimeter cancer. So it happens all the time. So if I followed the guidelines of ultrasound without alpha fetoprotein, I would hurt a lot of patients each year, and I would probably have a couple of patients dying who should not be dying. Next slide. If you can see here on the left side of the screen, there's ascites, but there's also near the spine, thank you for the arrow, there's a liver cancer that was picked up on CAT scan. There's potentially a curable situation right now. Next slide. This is a patient who was only picked up because she was pregnant. So she came to Hahnemann, she was pregnant. She was from South America, no risk factors for Hep B. They did an alpha fetoprotein, I think because of the baby. No, I'm sorry. They did a hepatitis B just because that's standard for what they do with pregnant women. And then they did an alpha fetoprotein. It was sky high. They thought it was the pregnancy. They did an ultrasound. She had a 3-centimeter mass. She refused to do anything until after her baby was born. This is the day after she delivered. You can see her cancer grew, probably tripled in size during her pregnancy. And if you look closely, you can see she's got a normal liver. So she was very fortunate. This was resected. A year later, she had a normal liver and she was cured. But again, going back, this is somebody who should have been picked up much earlier. So if we could identify all the Hep B patients in this country, we would not be in this situation. I have about 5 minutes left. Let's keep going. Okay. I'm going to go through a couple of studies that basically show that if you wait for symptoms, your survival is lower than if you survey patients for HCC. Next. This study looked at the presentation. If you did standard of care surveillance, 70% of the patients on the lower left were curable at the time that they presented. On the right top, if you didn't survey them, only 20% of them were curable. Same thing with survival, significant differences. So it's really important to do it. Next slide. And just another study showing improved survival if you screen patients for cancer. We will never do this trial again since it's been against the standard of care. Next slide. Last thing I want to really point out is it's just so important to send a patient with a liver mass to a center that has a multidisciplinary conference. All the big centers have this. There are many studies showing that the patient survival is improved if you go to a committee and take care of the patient. So anytime there's a mass, it should be presented at these group discussions. And we at Penn, I've done second opinions from the Virgin Islands to California all the time. Don't even have to see the patient, just send us the CD and a little history. Next slide. This is a study that showed that hepatitis B patients did not do very well in getting screened. Next slide. This was all over the country, a large number of patients. If you were older and had cirrhosis, you were more likely to get screened, but you can see only about 12% of these patients had imaging done once a year. So we really have a long ways to go. Next slide. So what are we doing to improve screening? We're using EMR. I just had a talk this morning with somebody who's going to help me do that. We're going to send out mail reminders. written contract with patients. We're even bribing patients to get screened. I'm involved in a clinical trial at Penn where half the patients will get a gift card of $50. If they get screened, they get the gift card. We haven't yet started bribing physicians. I think we should let radiology take care of this and help market and remind patients the way we do for mammograms and colonoscopy. But I really think that patient navigators are important. Collaboration with insurance company. with a project with an insurance company where I'm gonna work with them to look at their patients to see who's getting screened and who's not. Next slide. All right, so I'm down to probably my last 1 or 2 slides. How are we gonna improve the hepatic health of the US? As I said before, find, treat all the Hep C patients, same for Hep B, find and screen all the cirrhotics and all the surface antigen positive patients for hepatoma, identify hepatomas at an earlier stage with better screening modalities, eliminate the organ shortage. And I can't help but put a little plug in for assessing surgical risk. This is something that we did at Penn because I didn't like the Mayo Clinic score. I thought they overestimated the severity of illness. Next slide. Okay, so this is my last slide. My goal is to be on that beach on November 13th, 2030, which is my 70th birthday, which is my last day of work. Not sure if I'm going to be there on the 13th. I may want to be there on the 14th because depending on where I am, I may want to say goodbye at work and then have a great lobster lunch and then fly out that night or the next day. So anyway, I'm going to shut up now and take questions and go from there.
Great. Thank you so much, Dr. Rothstein. We've gotten some feedback on the presentation and so far positive for sure. We did have a couple of questions that came through the chat box, so I'll just go ahead and read those off. What level of AFP concerns you? And what ranges do you work with? Some values say normal, less than 6, others say 10 to 20 is acceptable. What are your thoughts on that?
Well, it really depends on the lab. I mean, because you're right, some labs it's 6, some it's 8, some it's 12. But you know, any elevated alpha fetoprotein gets me a little bit worried. And you know, I have a patient actually that's on my list to call today. His alpha fetoprotein's 24. I did an ultrasound, didn't show anything. I'm not comfortable with that. I'm going to get a CAT scan or an MRI. Many times we see an alpha fetoprotein slightly elevated because the liver enzymes are elevated. And there's really only one situation where an elevated alpha fetoprotein is good. That's with someone with acute hepatitis. If it's elevated, it means the liver is regenerating. And so a low alpha fetoprotein in that situation is a little scary. But along those lines, it's not necessarily the level, it's also the progression. So if I have someone with an alpha fetoprotein of 15, I will scan them, okay? And I have a couple of patients who run between 10 and 20, and I scanned them initially. I didn't scan them again because it didn't rise. But if I see it going from 15 to 30 to 45, I'm very concerned. Now, sometimes the CAT scan will not show the cancer and vice versa. The MRI won't, but the CAT scan won't, but the MRI will, and then vice versa. So my threshold for doing both a CAT scan and an MRI is 100, okay? Part of me thinks I should go down to 50, but I've had a couple of situations where I have an alpha fetoprotein above 100 where a CAT scan or an MRI is negative and the other test is positive. And my colleagues at Temple submitted an abstract to the liver meetings about that. So that's how I feel about alpha fetoproteins.
Thank you. Any other questions for Dr. Rothstein?
I thought you said you had multiple questions.
That was 2 questions.
So I had one that I accidentally just sent privately. And this is Adam Lake. Any evidence that HCC risk changes with HIV co-infection, and should we change our threshold to screen in patients with both infections?
Well, I will say this. I think Some people feel that it's slightly higher. Okay, I'm not 100% sure if it is, but no one has really come out and said we should change our screening protocol. I don't deal with a lot of co-infected patients, so I should know the answer. Maybe Dr. Fenkel knows the answer, but my guess is that it does slightly increase the risk.
Yeah, I would agree with that. Ken, I agree that it increases the risk slightly. In those patients, I definitely have a lower threshold for cross-sectional imaging, especially if they have steatosis from their antiretrovirals. You may not be able to see well enough on ultrasound. So those patients, I would at least try to alternate ultrasound and MRI every 6 months.
And I know we had another question as well. Dr. Rutland, was that you? Go ahead. Oh, you're muted. 1 second.
Okay, hi. Thank you, Dr. Rothstein. This is very practical. Just wanted to know, what is the time frame when you do the serial AFPs if you're watching to see if someone's elevating their levels?
It usually depends, but usually I'll do it within 1 to 2 months to see what's going on. But most patients are pretty nervous, so they usually want to do it on a monthly basis.
Thank you.
Mm-hmm.
Great. Any other questions?
Can I say one more thing?
Of course.
I fight so hard with insurance companies to get an MRI or a CAT scan when I need it. And I don't mean to say, I'm being taped, so I'll say this nicely. But if the alpha fetoprotein is 2 points above normal, they'll approve a CAT scan or an MRI. So I typically, just so I sleep better at night and the patient sleeps better at night, even with one elevated alpha fetoprotein, I will get some cross-sectional imaging while I'm following these patients.
Great. Thank you. Any other questions? All right, we'll monitor the chat box. So if you guys think of anything as we're moving through the case, I welcome you to submit those in the chat box. So at this time, I'd now like to move to our case session for today. Dr. Lake, I will